6:58 in the morning. A nurse covered in someone else's blood stood alone at the center of the emergency department, and 3 men in civilian clothes walked through the automatic doors and stopped the entire hospital cold. They didn't ask for directions. They didn't speak to the front desk. The oldest one, silver-haired, jaw like poured concrete, scanned the room once, found her across the chaos, and walked straight toward her. The nurses froze. The residents stared. Every person in that ER went quiet. And then that man stopped in front of the woman everyone had been mocking for 3 years and said, "Chief, we've been looking everywhere for you. Before we go any further, if you're new here, hit that subscribe button right now, because the stories on this channel don't pull punches. Every week, we bring you cinematic drama that will keep you up at night. Hit the like button, drop a comment telling me what city and country you're watching from. I want to see how far this story travels. Now, let's go back to the beginning. Because to understand what that moment meant, you have to understand everything they put her through first. Her name was Mara Doyle, 29 years old, 5'6". Brown hair she kept pulled back in a utilitarian knot that hadn't changed in 6 years. She drove a 7-year-old Subaru with a cracked rear bumper and a parking pass for the staff lot at Calvary Regional Medical Center in Dunmore, Pennsylvania, a mid-sized trauma hospital that served a stretch of rural and suburban communities spread across 3 counties. The kind of place where everyone knew everyone, where the hierarchy was rigid and unforgiving, and where a nurse who kept her head down and her mouth shut could disappear into the machinery of the place and just do the work. That was exactly what Mara wanted. She clocked in at 6:42 most mornings, 16 minutes before her shift technically started, because she'd learned early that the overnight nurses handed off badly and left problems for whoever came next. She'd spend those 16 minutes doing a walkthrough, checking supply levels, logging discrepancies, quietly restocking what had been used without being replaced. Nobody asked her to do this. Nobody thanked her. She didn't do it for either reason. The ER at Calvary ran on rotating trauma teams. Nurses, residents, tending physicians, all cycling through in shifts that created the illusion of continuity while actually producing constant gaps in communication and situational awareness. Mara had learned to navigate those gaps the way a person learns, to navigate a badly lit room, carefully, quickly, from memory. On the morning that everything changed, she was 3 hours into a 12-hour shift when Dr. Preston Garr walked in. Garr was the chief of trauma surgery at Calvary Regional, 47 years old, Harvard Medical, board certified in 3 subspecialties. His reputation had preceded him to Dunmore by nearly a year before he'd actually arrived, the kind of surgeon who appeared on panels, who published, who collected awards the way other men collected resentments. He was brilliant, and he knew it, and he made sure everyone within a 20-foot radius knew it, too. He walked into the trauma bay at 9:14 a.m. with 2 residents trailing him like ducklings, their white coats still crisp from the laundry, because they hadn't been on shift long enough to ruin them yet. The bay was mid-prep for an incoming MVA, a motor vehicle accident, on Route 6, estimated arrival 11 minutes out. Mara had already laid out the airway kit, verified the blood draw equipment, and was checking the defibrillator, defibrillates, when Garr swept past her without looking up from his phone. "Who staged this?" he said. "I did," Mara said. He glanced at the layout. His expression shifted, not dramatically. Dysplectin tightening, not dramatically. Just the slight tightening the eyes that meant he'd found something to correct. "Move the chest tube kit to the secondary cart. I don't want it competing with the airway setup for visual space." Mara didn't move immediately. Chest access is faster from this position, if we're dealing with a pneumo. Secondary cart puts it behind the attending's dominant side. Garr looked at her for the first time. He had the particular kind of gaze that certain powerful men deploy as a social weapon, not aggressive exactly, just relentlessly diminishing. The look that says, "I am deciding whether you're worth addressing directly." "Noted," he said, and turned to his resident. "Move the chest tube kit to the secondary cart." The resident, a young man named Fowler, who had been at Calvary for 4 months and had not yet developed the spine necessary to disagree with anything, moved the kit without making eye contact with Mara. Gar's other resident, a woman named Solis, who Mara had worked with twice before and found reasonably sharp, glanced sideways at her with an expression that conveyed something between apology and helplessness. Mara looked away first. She always looked away first. Cost her nothing. The MVA came in at 9:26, a 42-year-old man named Daryl Cobb, 3-car collision, driver's side impact, airbag deployed, obvious rib fractures on palpation, decreased breath sounds on the left. Classic high-mechanism blunt chest trauma. Gar worked him efficiently, called for a portable chest x-ray, ordered the standard workup. His technique was genuinely good. Mara had to give him that. What she also noticed and did not say was that Cobb's trachea was very subtly deviated. Not dramatically. Easy to miss if you were moving fast. She positioned herself where she could watch the monitor. Gar ordered the resident to push pain management. Mara said his pressure's drifting. Gar didn't turn around. He's in pain. That's expected. It's dropped 8 points in 4 minutes. Nurse. He said the word the way some people said child, not cruel, exactly. Just dismissive. I've ordered the x-ray. Let's get the data before we start theorizing. She watched the number on the monitor drop again. She said nothing else. She positioned herself 1 step closer to the chest tube kit, the one she'd originally placed at primary, now sitting on the secondary cart exactly where Gar had put it. And she waited. The x-ray came back 3 minutes later. By then, the pressure had dropped 14 points from admission. Gar looked at the image on the portable viewer and went still for exactly 2 seconds, which was the amount of time it took for him to recognize what he was looking at and recalibrate. Left-sided pneumothorax. Not tension yet, but close. And that tracheal deviation. Get the chest tube set up, he said, clipped. Fowler went to the primary cart first, automatically, then corrected himself and crossed to the secondary. Mara was already there. She had the kit open before Fowler reached her. She handed Gar what he needed in the order he needed it without being asked. Because she'd done this particular procedure enough times to know the sequence, and she did it with the efficiency of someone who had performed field interventions in conditions where hesitation had body count consequences. Gar didn't thank her. The procedure went fine. Cobb stabilized. Afterward, in the hallway outside the bay, Gar spoke to Fowler about the case. Mara was 3 feet away, documenting at a rolling workstation. Missed the tracheal shift initially, Gar said to Fowler. Easy to miss under pressure. The key is systematic assessment. You work through every marker in sequence. You don't skip steps. Mara kept typing. Fowler nodded earnestly. Gar glanced at Mara with something she couldn't quite read, not exactly contempt, not exactly acknowledgement. Somewhere in the narrow, uncomfortable space between them. He walked away. She typed the last line of the documentation and moved to the next task. The remainder of the morning was ordinary 2 lacerations, an asthma exacerbation in a teenage boy, a woman in her 60s with chest pain that turned out to be musculoskeletal and not cardiac, an elderly man whose family had brought him in for confusion that the triage nurse suspected was urinary tract infection. Mara moved through all of it at the same pace. She moved through everything steady, present, unsentimental. She ate lunch in 12 minutes in the break room, standing, because all the chairs were taken, and she didn't feel like asking anyone to move. The break room had a bulletin board covered in overlapping notices, holiday schedule, flu shot clinic, mandatory CFTT training due dates. In the corner, someone had taped up a picture from the hospital fundraiser gala 3 months ago. Gar was in the center of it, surrounded by board members and hospital administration, holding a glass of champagne and smiling the smile of a man who had never once doubted he belonged exactly where he was. Ate the last of her sandwich, threw the wrapper away, and went back to the floor. The afternoon was when things started shifting. Gore had a scheduled surgery at a complex case he'd been building toward for 2 weeks, and in his absence, the trauma floor settled into a different rhythm. The charge nurse on the afternoon overlap was a woman named Tina Marsh, who Mara had worked with for 2 years and found fair, direct, and substantially overworked. Marsh ran the floor with the pragmatic efficiency of someone who had stopped trying to make everything perfect and focused instead on making sure nothing actively collapsed. 2:17, a call came from the paramedic unit 3 minutes out. 17-year-old male workplace accident at a construction site. Fell from scaffolding, estimated 12 feet, landed on debris. Altered mental status en route. That was bad altered mental status after a fall from height meant traumatic brain injury until proven otherwise, and a kid that age with a TBI could deteriorate fast. Gar was in the OR. His senior resident, a third-year named Kwan, took the trauma lead by default. Mara began setting up. Kwan was smart, she'd watched him work before, and recognized that he was one of those residents who learned fast and genuinely cared about outcomes, which was rarer than people assumed. But he was also 3 years into training, and the gap between 3 years in and the kind of automatic pattern recognition expertise that only comes from thousands of hours of genuine crisis management was a gap he hadn't closed yet. Under pressure, that gap showed. The kid, his name was Marcus. She learned from the paramedic handoff. 17 years old, working a summer job his uncle had gotten him, came in with an oxygen sat of 91 and dropping a blood pressure that was holding but narrow, and pupils that the medics reported as unequal. Unequal pupils. That was the thing. Kwan started his assessment. He was systematic, methodical, moving through the primary survey the way he'd been taught. Mara ran the numbers on the monitor, drew bloods, set up the IV access, worked beside him in the wordless choreography of people who had done this enough to move without coordinating. "Sat's at 89, she said. "I see it. Prepping for intubation." "Pupils?" Kwan leaned in and checked. His face went a shade tighter. "Left's blown. Blown pupil on the left. Dropping oxygen saturation. Fall from height." She ran the math in her head, and it landed in a very specific, very bad place. "Could be a herniation pattern," she said. "If there's increasing ICP..." "I know what a blown pupil means," Kwan said. Not sharply, but with the controlled precision of someone managing their own stress response. "I know you do," she said. "I'm saying we may not have time for the CT. If he's herniating, we're not doing a burr hole in the ER." "No," she agreed. "But neurosurgery needs to be in this room right now, not in 5 minutes. And he needs hyperventilation and mannitol before we put him under." Kwan looked at her. There was a long half-second where she watched him weigh it, the question of whether she was right, against the question of whether listening to a nurse in front of his team would cost him something he couldn't get back. Called neurosurgery. Dr. Sandra Price, neurosurgery fellow, 41 years old, with a reputation for moving fast and a demeanor that made people assume she was angry even when she wasn't arrived in 4 minutes. She looked at Marcus for approximately 30 seconds before turning to the phone on the wall and calling the OR to hold a room. "Good catch," Price said to Kwan. Kwan nodded. Neither of them looked at Mara. Marcus went to surgery at 3:06. She didn't learn the outcome until much later, but she thought about him while she restocked the bay, going through the familiar motions of reset and prepare, the endless cycle of a department that was always either in crisis or waiting for one. At 4:45, Gar came back to the floor. His surgery had gone long, she could tell by the residual tension he carried, the slight clench in his jaw. That meant something hadn't gone the way he'd wanted. He read through the afternoon's notes at the nursing station, scrolling on the EMR terminal, with focused attention. Mara was doing medication reconciliation at the adjacent station. Quan handled the TBI case? Gare asked without looking up. Yes, she said. He called neuro? Correct. Gar scrolled. Notes say the concern about herniation came up early in the assessment. It did. He looked at her finally. Who flagged it? She met his eyes. I did. Something moved across his face, not quite gratitude, not quite displeasure. Something that sat uncomfortably in his expression, the way a piece of furniture sits wrong in a room when no one can quite figure out the angle. He turned back to the terminal. Make sure the documentation reflects the timeline accurately. It does, she said. He logged off and walked away. Mara finished the medication reconciliation and went to check on her patients. So her shift passed without incident. She gave report at 6:58, 12 hours in, exhausted in the particular way that had nothing to do with physical tiredness and everything to do with the sustained effort of being invisible, and was pulling on her jacket at the nursing station when Gar walked, passed with two other physicians she didn't recognize. He was telling a story about the surgery. His hands moved in the air, the way surgeons' hands do when they're reenacting their own competence. Two physicians laughed at something. His voice carried the warm, confident register of a man in the company of his equals. He passed her without seeing her, zipped her jacket, and walked toward the parking lot exit. The automatic doors opened on the cool evening air, the parking lot amber under its sodium lights, and she thought, tomorrow. Another shift. The same work. That was the life she had chosen. And she had chosen it deliberately, and she wasn't going to let a man like Preston Gar take anything away from it. She was almost to her car when her phone buzzed. A text from Tina Marsh. Heads up. Gar put in an incident report on your earlier interjection with the Cobb case. Said you overstepped. She stood in the parking lot for a moment. The sodium lights hummed. She typed back, noted, thanks for the heads up. She got in the car. She didn't sleep well that night, not because she was afraid, but because she was running calculations. How many incident reports before it became a pattern on paper? How much pattern before it became a personnel file? How much personnel file before it became something that required explaining to someone, explain fact she hadn't planned to explain anything to? She had things in her past that did not benefit from official scrutiny. She was careful. She had always been careful. But careful had a way of not being enough when the person filing reports had Gar's institutional weight behind him. In the morning, she drove back to Calvary Regional and clocked in at 6:42, 16 minutes early, and did her walkthrough. The overnight nurses had left 3 supply discrepancies and a medication cart that hadn't been properly locked. She fixed the discrepancies, logged the cart issue for the charge nurse, and positioned herself at the nursing station for the 7 a.m. briefing. Gare arrived at 7:08 and did not acknowledge her. She worked her shift. At 10:30, the incident report notification appeared in her employee inbox. She read it in the break room during a 6-minute gap between patients. Failure to follow physician directives. Unauthorized clinical commentary in trauma bay. Conduct inconsistent with nursing scope. The language was careful and institutional and almost entirely untrue, but it was formatted correctly and filed correctly, and it would sit in her record correctly until someone decided to look at it. Closed the notification and went back to the floor. By noon, she was aware that something was moving through the department the way rumors move not as a discrete piece of information, but as a shift in atmosphere, people's eyes doing that thing, where they almost land on you before sliding away. The incident report wasn't public, but hospitals are small ecosystems. And Gar was a man with enough social mass that his displeasure created weather. Fowler, who had been friendly in the neutral, arm's length way of someone trying not to make enemies, stopped meeting her eyes. Solis, who had more backbone, gave her a quick nod in the hallway that meant, I see what's happening, and I'm sorry, and there's nothing I can do. Mara kept working. 2:16, The following afternoon, 48 hours and 32 minutes after the Cobb case, Tina Marsh found her in the medication room and closed the door behind her with the careful precision of someone who knew the conversation they were about to have was going to be difficult. "They're moving you to nights," Marsh said. Mara looked at her. "Starting next cycle. Director of Nursing signed off this morning. Gar made a request through administration. It's not a demotion technically. The pay doesn't change. But it's a demotion," Mara said. Marsh's jaw tightened. "I tried to push back. I want you to know that. I went to Director Hollis directly, and I told her your documentation is clean. Your patient outcomes are excellent. I know you did," Mara said. "Thank you." Marsh looked at her with something that Mara recognized as the particular helplessness of a good person operating inside a system built to protect other people. "Is there anything you want to file? A counter-complaint? A grievance?" "No," Mara said. "Mara, I'll take the nights." She said it the way a person says something they have already processed and closed. "It's fine." Marsh left. Mara stood in the medication room for another 46 seconds, long enough to make sure no expression reached her face before she returned to the floor, and then she went back to work. She worked nights for 11 days. The night shift had its own logic, quieter in some ways, more chaotic in others. Fewer attending physicians meant more decisions fell to residents and nurses, which meant the people who actually knew what they were doing mattered more than the organizational chart usually acknowledged. Mara found a different rhythm there and adapted to it, because adapting was the one skill she had practiced longer than any other. She slept during the days in a bedroom she'd learned to fully blackout curtain. Ate at odd hours. She texted her sister in Spokane once a week, with enough normalcy to prevent concern. On the 12th night, everything changed. It started at 3:47 a.m., with a tone she hadn't heard in 3 years. Not literally, the same tone, Calvary's emergency mass casualty alert was a specific 3-burst pattern broadcast over the PA system, but a tone that her nervous system recognized before her conscious mind. Caught up, a sound that meant everything at once. She was already moving toward the nursing station when the PA finished its announcement. A 6-story parking structure at the Dunmore Commerce Center, 11 blocks from the hospital, had partially collapsed. Initial reports estimated 40 to 80 people were in or near the structure at the time of collapse. Multiple critical injuries en route. Calvary was the closest Level 2 trauma center they were receiving. She was in her trauma scrubs already. She started prep before the charge nurse had even finished activating the mass casualty protocol. There was a procedure for this. A binder in the emergency management cabinet that laid out the protocol in laminated tab pages describing the activation sequence, the staffing algorithm, the triage categories, the resource allocation decisions. She had read it. She had also spent 4 years learning mass casualty management in environments where the binder didn't exist, and you used what you had, and the only protocol that mattered was keep them alive. She began staging. Blood products, she calculated, they had 6 units of O negative in the emergency reserve. Probably not enough. She flagged the blood bank directly. IV access supplies, she broke 3 packs open and organized them by gauge. Airway equipment, she checked each laryngoscope blade under the harsh fluorescent light, replaced 1 battery, set up 2 video laryngoscopes and 1 surgical airway kit just outside the primary bay. Around her, the overnight staff was scrambling to get organized. The charge nurse, a man named Del Torres, competent, reliable, currently trying to simultaneously contact nursing administration, activate the recall list, and brief the 2 on-call residents who had just arrived, looking wide-eyed and undercaffeinated. First resident, a second-year named Patel, came to Mara's bay automatically because the setup was the most complete. "Who's running this bay?" Patel asked. "You are," Mara said. "I'll support." He nodded. She watched his hands. They were steady, which was a good sign. First patient came in at 4:04 a.m. A woman, mid-50s, crush injury to the lower extremities, conscious, in significant pain, blood pressure holding, Glasgow coma scale of 14. Serious, but survivable with the right intervention. Patel started his assessment. Mara was already cutting away the woman's clothing with trauma shears, locating vascular access points, talking to the patient. Can you tell me your name? I need you to stay with me. Okay, can you do that? While simultaneously reading the monitor numbers and registering the absence of Gar, who had been on call and should have arrived by now. He hadn't. The second patient came in at 4:07, third at 4:09. 4:15, every bay in the department was occupied. PA paged Gar at 4:06, then 4:09, then 4:12. He arrived at 14:21 minutes after the mass casualty protocol activated with his hair slightly wrong and a look on his face that a person who didn't know him might have read as urgency, but that Mara recognized as the controlled version of someone who had been asleep and needed 30 seconds more to fully arrive. He assessed the situation from the center of the department with the rapid scan of an experienced trauma surgeon. Who triaged? He demanded. Del Torres coordinated, Mara said from Bay 2. I staged primary and secondary bays. He turned to look at her. Good setup, he said. The words came out with the slight friction of someone who found the admission uncomfortable. Then he moved to the worst case in the room, which was a man in Bay 4 who had come in unconscious, multiple trauma, whose blood pressure had been dropping since arrival, and whose abdomen was rigid in a way that screamed internal bleeding. This was where the night turned. Gar moved fast. He assessed, ordered imaging, called the OR all textbook. All correct. He was running the case the way he ran every case, with the systematic, protocol-driven precision of someone whose training had been excellent and whose instincts had been honed in controlled environments. But Bay 1 had a different problem that nobody in the department had fully registered yet. Because Bay 4 was visible from the nursing station and Bay 1 was tucked behind a curtain that someone had half-pulled for a patient privacy reason that no longer applied. Mara had noticed it because she noticed everything. The man in Bay 1 was 43 years old, construction worker, blunt chest trauma from a falling concrete barrier. He'd come in talking GCS of 15, vitals initially marginal but not catastrophic. Pressure at 94 systolic, sat at 95. Patel had assessed him, logged him as serious but not immediately critical, and moved to the next case when the third arrival came in. Standard mass casualty triage logic. Treat the most salvageable first. Flag the stable ones for reassessment. Problem was that this man was not stable. He was quiet now, the kind of quiet that Mara recognized from a different context, a different life, a different her. Quiet that wasn't peace, but the physiological silence before the system gave out. She looked at his monitor from across the room. Pressure 87. Sat 91. Rate 128. She crossed to Bay 1. She put her hand on his chest, feeling, not just looking. Trachea had shifted. Subtle. Maybe 2 millimeters. But it had shifted, and his breath sounds on the right side were absent, and his neck veins were distending, and she felt the recognition drop through her like a stone hitting water. Tension pneumothorax, developing fast. He was minutes from cardiac arrest. She turned and called across the department, Bay 1 needs immediate attention. Developing tension pneumo. Gar was mid-procedure in Bay 4, hands in. He looked up. Patel's intubating Bay 3, she said. I need someone now. The second resident, a first year named Lynn, who had been doing admirable work at the edge of her competency all night, looked at Mara from Bay 2. Her eyes said, I'm not ready for this. Mara looked back at her. I know. She pulled the needle decompression supplies from the cart she had positioned exactly where she'd intended to position it. Primary cart, right hand access, and she moved. She didn't ask permission. That was the thing people would talk about later, not the skill, not the speed, But the fact that she simply moved without waiting for authorization from anyone. She positioned herself at the right side of the man's chest, located the second intercostal space at the midclavicular line. By feel the way she'd been taught to do it, in complete darkness, with noise and heat, and the specific quality of chaos that no simulation ever accurately reproduced. And she inserted the 14-gauge needle with the kind of mechanical precision that lives not in the brain, but somewhere deeper, somewhere that doesn't require conscious thought, because it was drilled in past the point of thought. The hiss of released air was immediate. The man's oxygen saturation, which had been falling toward 85 on the monitor, held, then climbed. His pressure, which had been compressing toward catastrophic, began to recover. Resident Lynn stood at the curtain opening, with her mouth slightly open. "Stay with him," Mara said. "Watch the pressure. If it drops again, you come get me immediately. Don't wait. Don't second guess. You come find me." Lynn nodded. She moved into the bay like someone operating on instinct when intellect had gone temporarily offline. Mara stripped her gloves and grabbed a fresh pair from the wall dispenser and moved to the next case. The department had reached the particular pitch of a mass casualty event that she recognized not from Calvary, not from anything in this building, but from a different context entirely. A memory she kept in a compartment she didn't open in the middle of night shifts. It was the sound of too many people in too much pain with too few hands available, the sound of equipment and voices and monitors all lousled into something that from the outside would have seemed like pure chaos, but that she could read the way a person reads, a room scanning for the variable that was about to break bad, filtering out the noise, staying 3 moves ahead. Gar was calling for the OR team in Bay 4. His patient was going up. That was right, that patient needed a surgeon, needed a controlled environment, needed interventions that required infrastructure. She didn't second guess it. What she did was take inventory. Occupied bays, 3 residents working. Del Torres coordinating logistics at the station, but pulled thin across multiple phone calls, blood bank, additional staffing, hospital administration demanding updates, while a mass casualty event was actively in progress, which was the administrative equivalent of calling a driver to discuss fuel efficiency while the car was on fire. The 2 nurses who'd come in on the overnight recall, a man named Garrett, who was solid if slow, and a woman named Patterson, who moved fast but had a tendency to freeze at decision points, were doing good work in bays 5 and 6. She mentally filed them away as reliable within their lane, which left bays 7 and 8. Bay 7 had a teenage girl, maybe 16, hard to tell with the swelling across her face, who had been logged as stable on triage. Closed head injury, GCS 14 on arrival, cervical collar, no obvious spinal deficit. Stable? Yes. But the girl's left arm was positioned wrong. Not the way a person positions their arm when they're in pain and trying to protect it. The way a person's arm positions itself when the nervous system has stopped fully communicating with the limb. Mara stopped at the curtain. "Hey," she said, "can you squeeze my hand?" The girl looked at her. Her right hand gripped immediately, strong. Her left hand did nothing. "Can you try the left?" A long pause. The girl's eyes went to her left hand with the particular look of receiving information about their own body that they hadn't yet processed. "It feels far away," she said. That was a sentence that required a call to neurology. Mara flagged it in the system immediately, marked it urgent, and kept moving. Bay 8 was a man in his late 60s. Compression fracture visible on the portable film someone had run, blood pressure high too high, 178/96, which could be pain response or could be something else. She checked his medications on his wallet card, which the paramedics had brought in with his belongings. He was on 2 antihypertensives. His pressure at 178 on 2 blood pressure medications meant his actual baseline was probably significantly lower. And at this pressure, with a compression fracture, any undetected intracranial involvement became a different kind of risk. She ordered the CT through the system and moved on. She was at the supply cart pulling additional IV kits when Gar came back from escorting his Bay 4 patient to the elevator. He stopped in the center of the department and did the same sweeping assessment he'd done on arrival. But now his face was different. The surgical, focused look had given way to something more calculating, the expression of a man trying to account for the whole board rather than one piece. His eyes landed on her. Bay 1, he said. Tension pneumo, decompressed. Lynn is monitoring. Pressure recovering. He looked at Bay 1. Then at her. Who decompressed? I did. Apartment noise continued around them. Monitors, voices, wheels on linoleum. Someone in Bay 3 coughing against intubation. And Gar stood with that information for 3 seconds. That felt longer than they were. On what authorization? She held his gaze. He was 40 seconds from arrest. Gar's jaw moved. He was doing the calculation she already knew. The answer to patient was alive. Intervention was correct. Outcome was good. But the protocol question was real, and he was a man who operated inside protocol the way other men operated inside their own skin. We'll discuss this after, he said. Fine, she said. He turned to assess the department, and she turned back to the supply cart, and they both went to work because there was nothing else to do. The next 2 hours were the kind of work that doesn't look like anything from the outside. No dramatic moments. No single clear event, just the sustained, grinding, technically demanding labor of keeping people alive in conditions that were not designed to keep this many people alive simultaneously. She moved through the department in a pattern she was building in real time, covering gaps, flagging deteriorations, running supplies, coordinating the residents who were working hard but who needed someone to function as their institutional memory for the night. Patel, who had been the most nervous on arrival, found his footing by 5 a.m. She watched it happen, the shift from conscious competence to something more automatic. The way the anxiety in his movements smoothed out as his training kicked in past the adrenaline. She made a mental note to tell him later, if there was a later, that he'd done well. People in training rarely heard that with enough specificity for it to stick. Lynn stayed with the Bay, 1 patient through 2 reevaluations, and correctly identified when his pressure began drifting again at 4:51, and came to find Mara exactly as she'd been told to. Patient needed a chest tube, a more definitive intervention than the needle decompression, something that would require physician involvement. She brought Lynn to Gar, who was between cases, and presented the situation. He's reaccumulating, she said. Needs a tube. Gar evaluated, agreed, and placed the chest tube with Mara assisting. He didn't thank her. She didn't need him to. The tube went in correctly, and the patient's numbers improved, and that was the outcome that mattered. The teenage girl in Bay 7 got her neurology consult at 5:12. The attending who came down, a man named Vargas, who was brusque and competent in equal measure, took one look at the arm presentation and ordered an emergency MRI. Good catch, he said, to nobody in particular while writing the order. Mara was the only other person in the bay. She said nothing. The man in Bay 8 had his CT results back by 5:30. No intracranial involvement, which was the best possible answer. His pressure had come down to 154 with IV medication, which was still high but now manageable. She updated his chart and flagged him for the on-call internist, who was somewhere in the building being pulled in 4 directions. By 6:15, the acute chaos had moved into the sustained emergency phase, the part where the immediate survivability crises were addressed and the longer-term management questions were taking over. New patients, New patients had stopped arriving, the scene at the parking structure had been stabilized, and the remaining casualties were being distributed to other regional facilities. Calvary had received 23 patients across the night. 3 had gone to the OR. One had gone to the ICU directly. The rest were in various stages of assessment and stabilization. Nobody had died in the ER. Mara knew this because she'd been keeping track. She sat on a rolling stool at the nursing station at 6:18 and drank half a cup of water and stared at the board for exactly 90 seconds, which was the amount of time she allowed herself before starting the documentation, catch-up that mass casualty events always left in their wake. Charting was unglamorous and essential, and she was good at it, which meant she was always the person doing it when everyone else was still processing. Gar came to the station at 6:24. He sat down in the chair beside her, not a thing he had ever done before, in her recollection. Not in 11 days of night shifts, and not in the months before that, when she'd been on days, and he'd treated the nursing station as a place he passed through rather than occupied. He didn't say anything for a moment. He was looking at the board, too. Bay 1 patient is stable, he said finally. I know. Neurology called down. The girl in Bay 7 has a C5 contusion. They caught it early enough. Good. Another pause. The needle decompression, he said. That was correct. In terms of the clinical picture, she waited. I'm not saying the protocol question isn't real, he said. Because it is real, and we are going to have a conversation about scope and authorization that I am not going to enjoy, and neither are you. Understood, but he stopped. The word sat there like something he'd put down on the counter, and wasn't sure he wanted to pick back up. Patient is alive. Yes, she said. He got up. He refilled his coffee from the station carafe and walked toward the physician workroom. At the doorway, without turning around, he said, Good work tonight. She watched him go. She turned back to her charting and typed the next line of documentation and did not think about what that had cost him to say, or what it had cost her not to say anything back, or the fact that the incident report he had filed 4 days ago was still sitting in her personnel file, making its quiet institutional damage. Typed another line. She kept working. The day shift arrived at 7 a.m. with the particular energy of people who had slept and were arriving into the aftermath of something significant, the busy, half-informed alertness of people trying to catch up to events they hadn't witnessed. The charge nurse coming on, a woman named Abrams, took one look at the board and the documentation load and the expression on Del Torres's face and said, How bad was it? Manageable, Torres said. He glanced at Mara. She said nothing, pulled on her jacket, gave her report to the oncoming nurse, and clocked out. In the parking lot, the morning had arrived fully pale, October light, cold air with the particular sharpness of a Pennsylvania autumn that meant the warmth was done for the year. She sat in her car for a moment and ran through the night the way she always ran through shifts afterward, systematic, looking for errors, looking for the moments where a different decision might have produced a different outcome. She found 2 places where it had moved faster than the documentation reflected, which meant she needed to add supplemental notes to 2 charts before the records could be considered complete. She would do that when she got home. She had remote access to the charting system through the hospital's encrypted portal, a feature that had been intended for physicians, but that she'd quietly gotten credentialed for 8 months ago when the nursing director at the time had been more flexible about such things. She drove home through the morning commute, which moved the way morning commutes always move when you've been awake. All night the traffic feeling simultaneously too slow, and somehow not quite real. Ordinary world of people driving to ordinary jobs, sitting at a slight remove from her own experience of the last 7 hours. Her apartment was the 2nd floor of a converted Victorian house on Aldous Street, 8 blocks from the hospital. She'd chosen it partly for the proximity, old habit, old reflex, and partly because the landlord was a retired postal worker named Brundage, who fixed thick things when they broke and otherwise left her alone, which were the only 2 qualities she required. She made eggs, not because she was hungry, but because protein was necessary, and eggs were fast. She ate standing at the counter, looking out the window at the backyard, a rectangle of grass, with a single maple tree that was most of the way through its autumn color, the leaves going orange at the edges, while the center still held green. She thought about the bay one patient whose name she hadn't gotten a chance to learn. She thought about the teenage girl with the cervical contusion who was probably in an MRI machine right now, or had been, and whose arm had felt far away. She washed the plate. She added the supplemental chart notes through the encrypted portal. She pulled the blackout curtains and slept. She woke at 3:17 p.m. to 3 notifications. The first was from Torres, heard from day shift. Boy in Bay 7 is going to need PT, but full recovery expected. Thought you'd want to know. The second was from a number she didn't recognize, which turned out to be a hospital administration extension when she looked it up. A voicemail requesting she come in for a meeting with the director of nursing and doctor. Gar at her earliest convenience, which was administrative language for tomorrow morning, whether it's convenient or not. The third was from her sister in Spokane. Haven't heard from you. Just checking in. Call me sometime? She looked at the 3 notifications in sequence. She called her sister back and talked for 11 minutes about nothing important. Her sister's kids, a renovation project, a neighbor dispute about a fence line. Normal things. The texture of a life that was not built around mass casualty events and incident reports and men like Gar who filed paperwork as a weapon. After she hung up, she sat for a moment and thought about the meeting. She had 2 possible framings for it. The first was that Gar had, in the aftermath of the night's events, decided to pursue the scope of practice violation formally and was using the administrative meeting to build the documented case that would precede termination. This was possible. He had the institutional weight to make it happen, and a personality type that did not easily absorb the experience of having been wrong about someone. Sexinets. The second was that the night had shifted something, and the meeting was a different kind of conversation. She didn't know which. She couldn't know until she was in the room. She had functioned in conditions of far greater uncertainty, with far higher stakes, and she could function in this. She confirmed the meeting time and went back to sleep. She arrived at the administrative wing of Calvary Regional at 8:50 a.m. The next morning, 10 minutes before the scheduled time, because arriving early was how she managed rooms before she entered them. The administrative wing was carpeted a detail that always struck her as slightly incongruous with the rest of the building. The abrupt transition from linoleum and fluorescence to the muffled, neutral tones of institutional management. The director of nursing was a woman named Hollis, mid-50s, with the contained energy of someone who had spent decades managing problems that human beings created for each other in high-stress environments. Mara had interacted with her twice before, once about the schedule change, once about a supply chain issue that had reached the director level because someone hadn't resolved it lower down. Hollis was fair. She was also political, which was not the same thing as unfair, but was a quality worth tracking. Gar was already in the room when she arrived. He was seated across the table from Hollis, which put Mara's chair at the end, the structural position of someone being addressed by 2 people rather than speaking with them. She noted it and sat down without comment. "Thank you for coming in," Hollis said. "I know you're coming off nights." "It's fine," Mara said. Hollis had a folder on the table. Mara recognized the format personnel file summary. Her name was on the tab. "We wanted to address 2 things," Hollis said. "The incident report filed earlier this week and the events of last night." She paused. "Those 2 things are in some tension with each other, which is why we thought it was better to address them together." Gar was looking at the table, not evasively. He'd never been evasive in the time she'd known him, which was one of the things she found genuinely difficult about him as an adversary. He was direct in his dismissals. He was direct in his corrections. He was, she suspected, working on being direct about this too, and finding it harder than he'd anticipated. "The incident report reflects a real concern about protocol," Gar said. "I want to be clear about that. The scope of practice question is not academic. When nurses make unsolicited clinical interventions, the patient was about to arrest, Mara said. I know. I said that in the room, and you told me to let the data come back. I know that too. He said it without defensiveness, which was harder to respond to than defensiveness would have been. And the patient deteriorated in the interval between my order and the X-ray return. That's documented. Hollis looked between them with the expression of someone watching a conversation they expected to have to manage, and finding it was managing itself. Protocol question and the outcome question are not the same question, Gar continued. The outcome was correct. Your clinical read was correct. The method by which you intervened requires a different framework than what currently exists for your role. Mara waited. Which is what we'd like to discuss, Hollis said. She opened the folder, your nursing credentials, your continuing education record, your clinical performance data over 3 years at Calvary. She ran her hand down the page, which is, frankly, exceptional. Mara said nothing. We're also aware that you have some kind of prior background that you have not disclosed to us. Hollis looked at her directly, not accusingly. You're not required to disclose it, but given last night's events, it's become somewhat relevant. The room was quiet. The question sat there, not quite asked, not quite unasked. Hollis was smart enough to not demand an answer. She was creating space for one. Mara looked at the wall behind Hollis's shoulder for a moment. Then she looked at Gar, then at Hollis. I have a clinical background that predates my nursing certification, she said. I'm not in a position to discuss the specifics. Hollis nodded slowly. That's your right. What I can tell you is that the interventions I made last night were within my actual competency. Protocol question is legitimate. The outcome supports the competency. Gar looked up from the table. He had a particular expression that she hadn't seen on him before, not quite respect, but the thing that lived next door to respect in people who had been built by institutions that made respect difficult. There's a designation, he said, a clinical privileging pathway. It's outside the standard nursing track. It would require documentation and credential review. He paused. It would also require me to submit a supporting recommendation. She looked at him. I'm telling you it exists, he said. I'm not telling you anything else right now. Understood. Hollis closed the folder. The incident report will remain on file because it reflects a real event, and we don't retroactively remove documentation. What we can do is add a responsive note that contextualizes the outcome and the circumstances. She looked at Mara. That would require your written consent. You have it. We'll also be returning you to the day shift, starting next cycle. Hollis's tone was even, neither apologetic nor entirely neutral. The night reassignment is no longer appropriate, given the current situation. Mara waited for something else. There wasn't anything else. All right, she said. She stood. Gar stood a beat after her. He reached across the table, not for a handshake exactly, but with the slight extension of a man making a gesture he hadn't fully worked out, and then pulled back and looked at her instead. You should have told me what you were, he said. She picked up her jacket from the chair. You made it clear you weren't interested. She walked out of the administrative wing, back onto the linoleum, back into the sound and smell of the hospital, and she was halfway to the elevator when her phone buzzed. She looked at it. An unknown number. Not an extension, this time an outside line. A 703 area code, Northern Virginia. She stopped walking. The 703 area code meant one thing to a very specific kind of person, with a very specific kind of past. And she was one of those people. And she had spent 3 years building a life specifically sized to exclude whatever was on the other end of a call from Northern Virginia. Phone buzzed again. She stood in the hallway with the elevator 30 feet ahead and the phone in her hand, and the accumulated weight of 3 years of careful, deliberate, unglamorous ordinariness sitting in her chest like a stone. She answered it. The voice on the other end was one she recognized immediately, not because she'd heard it recently, but because some voices get written into memory at a depth that time doesn't reach. Chief Doyle, the voice said, 3 years of distance collapsed in an instant. How did you find this number? She said. Not a question, a statement. The particular non-question of someone already doing the math on what finding this number required. We need to talk, the voice said. Not on the phone. She looked at the elevator doors, at the hallway, at the ordinary fluorescent-lit corridor of a regional trauma hospital in Dunmore, Pennsylvania, which was supposed to be, for all practical purposes, the rest of her life. What happened, she said. A pause on the other end. Just long enough to mean the answer wasn't simple. Just long enough to mean that whatever was coming was going to arrive, whether she wanted it to or not. There's a situation developing, the voice said, and you're already in the middle of it. She didn't move from the hallway for another 3 seconds. 3 seconds was enough time to make a decision, or at least to recognize that the decision had already been made for her by whatever was on the other end of a 703 number calling a phone that should not have been findable by anyone who knew what a 703 number meant. Where, she said. Calvary Regional, the voice said. We're already there. She looked down the hallway, at the elevator, at the ordinary mid-morning traffic of a hospital in motion. An orderly pushing a wheelchair, a family walking toward the visitor elevator with the particular compressed anxiety of people going to see someone in a room they don't want to be in. How long have you been in the building? She said. Long enough to know you had a productive night. A pause. We need 30 minutes. There's a conference room on the 3rd floor, East Wing, that's currently unscheduled. She knew the room. She'd sat in it twice for mandatory training sessions she hadn't wanted to attend. Give me 10 minutes, she said. She used 7 of them to go to the women's restroom on the 2nd floor, run cold water over her wrists, and look at herself in the mirror for long enough to do what she had learned to do in a different life when circumstances required. Put down everything she'd been carrying and pick up a different version of herself. Not a performance, more like a gear shift. The Mara Doyle, who had spent 3 years building something small and manageable and deliberately bounded, had to step to one side, and the person she'd been before the one she'd spent 3 years specifically not being had to take the wheel. She dried her hands, straightened her scrub top, walked to the elevator. The conference room had a long table, 8 chairs, and a whiteboard with someone's 3-week-old project timeline still on it in dry erase marker. The blinds were half down. The overhead light hummed at the particular frequency that made long meetings feel longer. 3 men were in the room. She knew one of them. The voice on the phone had belonged to a man named Aldrich Voss, 53 years old. Short gray hair, cut with military precision. A jaw that looked like it had been designed to absorb bad news and stay level. He'd been her commanding officer for the last 18 months of her operational career, before the decision that had ended it. He was in civilian clothes dark jacket, no visible insignia, but the posture was unarrestable. She hadn't seen him in 3 years, 2 months, and some number of days she hadn't been counting. The second man she didn't know mid-40s, compact, with the watchful stillness of someone from an intelligence discipline rather than a medical or operational one. He had a laptop open in front of him and a folder on the table, and he didn't introduce himself when she came in, which was itself information. The third man was younger, late 20s. She clocked the way he held himself near the door and understood immediately that he was the room's security awareness, which meant whatever was in this conversation had a physical threat dimension that the other 2 considered relevant enough to bring a body for. Voss stood when she came in. "Chief," he said. "I'm not chief anymore," she said. She sat down without being invited, because waiting to be invited was a status signal she wasn't prepared to give. "What's the situation?" Voss sat back down. He looked at her with the expression she remembered direct. Measuring, not unkind but not soft either. the expression of a man who had sent people into bad situations many times and had learned to be honest about what he was doing and why. 3 weeks ago, he said, a Category 2 biological containment event was flagged at a federal research facility in upstate New York. The facility is designated Whitmore Station. It operates under a research and development mandate that I'm not going to detail in this room. She waited. The event involved a modified respiratory pathogen, not naturally occurring, lab-developed, intended for study under controlled conditions. Containment failure occurred during a transfer protocol. 4 researchers were exposed. 2 have since recovered. 1 died 9 days ago. And the 4th, she said. Voss's jaw moved slightly. The 4th exposure case was transferred 6 days ago to Calvary Regional under a cover identity. Respiratory distress presentation. He's currently in your ICU under the name Thomas Ray. She felt something go very still in her chest. You have a patient in this building, she said carefully, with a modified respiratory pathogen of unknown transmission profile. The pathogen's transmission profile is actually well documented, the intelligence man said, speaking for the first time. His voice was neutral, professionally so. It requires direct biological fluid contact or sustained close-range respiratory exposure. It's not airborne in the conventional sense. The transmission risk to hospital staff is low with standard precautions. Low, she said. Assessed at low, not 0. She turned back to Voss. Why is he here? Why is he in a civilian hospital with a cover identity and not at a federal medical facility? Because getting him to a federal medical facility required transporting him through 2 jurisdictions with surveillance we weren't comfortable with, Voss said. And because Calvary Regional has a pulmonary ICU with the specific equipment his condition requires. And because we have an asset at Calvary. He paused. We had an asset at Calvary. She looked at him. There was a physician on staff here who was read into the operation 18 months ago, Voss said. Dr. Raymond Kessel, pulmonology. She knew the name, not personally, but she'd seen it on charts past him in hallways. Older man, quiet, unremarkable, in the way that some very competent people are unremarkable. Kessel had a cardiac event 4 days ago, Voss said. Currently in the cardiac ICU at Mercy General in Scranton. He is alive, but not functional. 4 days ago, she said. So for 4 days, your patient in my ICU has had no read-in physician managing his actual condition. He's been managed by the standard ICU team, the intelligence man said. Cover presentation, atypical pneumonia, is consistent with what they're treating. Supportive care is appropriate, but they don't know what they're actually dealing with, she said. No. She put both hands flat on the table and looked at them for a moment, then looked at Voss. What's happening to him, she said, clinically. What's the actual disease progression? Voss looked at the intelligence man, who opened his folder and turned it toward her. Clinical data. Labs, vitals, imaging, the actual record, not the cover chart. Pulled it toward her and read it the way she'd been trained to read medical reports, fast, structured, looking for the numbers that diverged from the narrative. The divergences were significant. His inflammatory markers were running far higher than his documented presentation would explain. His oxygenation was deteriorating in a pattern that didn't fit atypical pneumonia, too rapid, too specific in its distribution. The chest imaging showed bilateral involvement with a characteristic infiltrate pattern she'd never seen in a naturally occurring respiratory illness, but recognized from research literature she'd been read into during a specific operational period she didn't think about often. He's developing ARDS, she said. Correct. And the standard ICU team is managing him for atypical pneumonia, which means they're using a treatment protocol that is what? 50% appropriate? The supportive care overlap is significant, the intelligence man said. Ventilator management, fluid, strategy, positioning those translate. The specific immunomodulation he needs is not in the standard protocol. She looked at the labs again. His ferritin was catastrophic. His D-dimer was climbing. The coagulopathy developing in the margins of this picture was the thing that was going to kill him. And the ICU team managing him for pneumonia would likely interpret those markers as disease progression and escalate ventilator support when what he actually needed was a different pharmacological approach entirely. How long, she said, before the divergence becomes fatal without correct intervention? The intelligence man looked at the data. 12 to 18 hours, possibly less if the coagulopathy accelerates. She sat back. You need someone read in to take over his clinical management, she said. We need someone who can operate inside this hospital, who has the medical competence to manage his actual condition, and who is already credentialed here. Voss looked at her. You're the only person currently at this facility who meets all three criteria. I'm a nurse, she said. You're a special operations combat medic with 18 Delta Advanced certification, field credentialing in advanced airway and surgical intervention, and 4 years of operational experience, treating complex trauma and infectious disease presentations in austere environments. He said it with the flat precision of someone reading a file. You also just spent a night managing a 23-patient mass casualty event by yourself, which confirms that your practical skill set has not degraded. You were watching, she said. We've been monitoring the situation since Kessel went down, he said. We needed to assess whether you were still operationally viable. She thought about that for a moment. The mass casualty event. Voss said nothing. The parking structure, she said. That wasn't. No, he said, that was a structural failure. That had nothing to do with us. We didn't manufacture a crisis to test you. He paused. We were simply watching how you handled the one that occurred. Couldn't entirely decide if that was better or worse. I need to see the full pharmacological protocol, she said. And I need physician cover. I can't adjust his medication regimen without a physician signature. We're working on read-in authorization for one of the ICU attendings, the intelligenceman said. That process will take approximately 6 hours. He may not have 6 hours, which is why we're here now rather than waiting for the process to complete. She looked at Voss. You're asking me to intervene in a patient's care without proper authorization, using a treatment protocol derived from classified research, in a civilian hospital where my scope of practice is already under scrutiny from an active incident report. Yes, Voss said. That is an accurate summary, and if something goes wrong, then we were never here, and you made independent clinical decisions based on your nursing assessment. She looked at him for a long moment. That's a terrible answer. I know, he said. I'm sorry. She stood up because sitting still while making this kind of decision was not something she'd ever been able to do. She walked to the window and looked out at the parking lot, ordinary morning light, ordinary cars, a woman in a green coat walking toward the entrance with a child who was trying to step on every crack in the pavement. What's his actual name? She said. Voss hesitated one beat. Callum Reyes. He's 37. He's a research microbiologist. He has a daughter in Phoenix. She turned around. Get me the protocol, she said, and get me access to the real chart. His room was 412, ICU East. She had been on that unit before her hospital access wasn't restricted by floor, and her 3 years of consistent presence at Calvary had made her a familiar face in most departments. The ICU nurses knew her as the ER nurse, who sometimes came up to follow patients through, which was unusual but not unprecedented. Nobody questioned it. She reviewed the cover chart first, standing at the nursing station terminal, building the picture of what the ICU team believed they were dealing with. They'd done good work with the information they had. His ventilator settings were reasonable for the presentation they saw. The fluid management was conservative, which was correct. His sedation was light enough to allow neurological assessment, which was appropriate. What they hadn't done, couldn't have done, was address the inflammatory cascade that the real data showed was accelerating. His ferritin, last drawn 18 hours ago under the cover protocol, had been 3,200. She pulled the most recent available labs and found that the trend lines predicted it was substantially higher now, which meant the cytokine storm process was running and the window to interrupt it was closing. She went to his room. Callum Reyes was in the bed with the particular stillness of a heavily sedated person, on mechanical ventilation present, but inaccessible, the body's architecture visible while the person's inside was somewhere beyond reach. He was thinner than the file photos Voss had shown her. His color was wrong, not gray of acute crisis, but the yellow undertoned pallor of a liver working too hard. His current nurse, a woman named Park, who was experienced and attentive, and who Mara knew by sight without knowing well, was adjusting his IV lines when Mara came in. "Are you following him from the ER?" Park asked. "He came through our department on admission," Mara said. "I wanted to check in on his progress." Both sentences were technically true. Park glanced at the chart on the room terminal. He's been holding. Not improving much, but holding. Pulmonology was in this morning. What did they say? Escalating the steroid protocol. They're seeing more infiltrate on this morning's film. Park's expression was the professional neutral of someone who had seen enough to know that holding but not improving often had a limited runway. Family's been notified he's critical. Mara looked at the monitor. His oxygen requirement had increased since the last notation in the cover chart. His pressure was maintained, but the numbers had the fragile quality of a system that was compensating rather than recovering. She looked at his hands. The distal perfusion was marginal, not critically compromised yet, but trending in a direction that, combined with the D-dimer she'd seen in the real data, told her the microclotting process was underway. "Has anyone pulled a fibrinogen level?" she asked. Park looked at the chart. "Not since admission. I'd want to see a current fibrinogen and a repeat D-dimer. And if the attending is amenable, a ferritin." She said it with the measured tone of someone raising a clinical observation, not a directive. His hands looked like his clotting cascade. Might be worth watching. Park looked at his hands, then at Mara. "I'll flag it for the attending when they round." "Thank you," Mara said. She spent another 2 minutes in the room. She wasn't able to do anything yet. Not without the pharmacological protocol Voss's team was arranging to get to her, and not without the physician cover that was still 6 hours away through official channels. But she was building the picture. Building the picture, the IV access points, assessing the current medication setup, understanding the monitoring configuration. She left the room and went back to the hallway and found a supply alcove that was empty at this time of morning and stood in it and looked at her phone. A message from the intelligence man, no name in her contacts, just a number. Protocol documentation sent to secure drop. Access through the portal you use for remote charting. Folder labeled Audit Review. Delete after reading. She accessed the portal through her phone, found the folder, and read the protocol, standing in the supply alcove, with the door half open, and the sounds of an ICU in mid-morning operation around her. The protocol was 17 pages. She read it in 9 minutes, which was faster than reading and slower than the absorption she needed. So she read the critical sections twice the immunomodulation sequence, the anticoagulation approach, the monitoring parameters that diverged from standard ARDS management. It was elegant, in the way that dangerous things sometimes were precisely targeted, the margins tight, the interactions between the medications requiring a sequence and timing that was unforgiving of imprecision. Deleted the file. She stood in the alcove another moment. The problem was the physician cover. 6 hours was too long. She could see from the data that 6 hours was likely too long. And the solution to that problem was a conversation she had not anticipated having today with a man she had a deeply complicated professional relationship with, who was going to ask questions she couldn't answer fully. Pulled up Gar's extension and called it. He answered on the second ring. "Gar, it's Doyle," she said. "I need 10 minutes. It's about a patient in the ICU." I think it's urgent. Pause. I'm not the ICU attending. I know. I'm not asking you as an ICU attending. I'm asking you as the person in this building who makes decisions when something doesn't fit the documented picture. She waited. Please. Another pause, longer. Physician lounge. 5 minutes. She got there in 3. Gare arrived looking like a man who had slept badly and whose morning had already been long. He had coffee. The physician lounge had a decent machine, one of the small institutional status markers that separated the spaces, and he sat across from her and looked at her with the expression of someone preparing for a conversation he couldn't predict. She told him as much as she could. Not the origin of the pathogen. Not Whitmore Station. Not Voss or the men in the third-floor conference room. She told him that she had reason to believe that the patient in 412 had a presentation that was more complex than his documented diagnosis reflected, that his inflammatory markers and coagulation profile suggested a specific cascade that the current protocol was not addressing, and that she had clinical knowledge from a prior professional context she couldn't files. He proved that was relevant to his treatment. Gar listened without interrupting. He was good at that, she had discovered. When he chose to listen, he actually listened. When she finished, he was quiet for a moment. You're telling me a patient is being mismanaged, he said, but you can't tell me how you know that. I'm telling you his current trajectory is concerning, and that there are specific labs that would either confirm or disprove what I'm thinking. Which labs? She listed them. Fibrinogen, ferritin, repeat D-dimer, LDH, full coagulation panel. He looked at her across the table. You recognized a pathological pattern from a context you can't discuss. Yes, and you want me to order labs on a patient who is not under my service, based on a clinical concern from a nurse who is not credentialed in the ICU for reasons she can't explain. I want you to look at the labs and tell me if I'm wrong, she said. If I'm wrong, nothing changes. If I'm right, we have a conversation about what to do next. Turned his coffee cup in his hands. She watched him thinking the visible, working quality of his intelligence, which she had always found genuinely formidable, even when she'd resented how he deployed it. This has to do with whatever you are that you won't tell me, he said. She met his eyes. Yes. And if I ask the ICU attending directly? He doesn't know what I know, she said. Nobody at this hospital does. Except, now, you. He stood up. He walked to the window, which faced an interior courtyard where a single tree was doing what the maple on her street was doing, running out of summer, dropping color into the cold. He stood there for a moment with his coffee. If I order those labs, he said, and the results come back consistent with what you're describing, what happens next? There's a treatment protocol, she said. I need a physician's signature. You want me to sign off on a treatment protocol I haven't reviewed from a source you haven't disclosed. I want you to review it, she said, and then decide. He turned around. Get me the protocol, he said. She had the printed pages, a redacted version, stripped of origin information, clinical content only in her jacket pocket. She had put them there on the way from the alcove because she had known this was where the conversation was going. She set them on the table. He looked at her. He looked at the pages. He sat back down and picked them up. She waited while he read. He read carefully. She watched his eyes move across the text with the thoroughness of a surgeon reviewing something he was going to be held accountable for, which was exactly what he was doing. He made one note in the margin of page 3, which was the page that covered the anticoagulation protocol. When he finished, he put the pages down. This is sophisticated, he said. Yes. The interaction between the immunomodulation and the anticoagulation, the timing window is very tight. I know. If the ferritin comes back consistent with what you're predicting, he stopped. Started again. If this is what you think it is, and we intervene with this protocol, and something goes wrong. If we don't intervene, and his coagulopathy progresses, she said, he will have a catastrophic bleeding event in the next 12 hours. Possibly his brain possibly his lungs. That is what wrong looks like on the current trajectory. Gar looked at her for a long time. "I'll order the labs," he said. "And when they come back, I want to be in the room for whatever conversation happens next." "Thank you," she said. "Don't thank me yet," he said. "I haven't done anything I can explain." She picked up the redacted pages and put them back in her pocket and walked out of the physician lounge and took the stairs up to the 4th floor because she didn't want to wait for the elevator. The ICU was moving at its midday pace when she came back through. She positioned herself where she could see room 412's window. There was a direct sightline from the nursing station area, and she watched the monitors through the glass and did math she hoped she wouldn't need to use. The labs came back at 1:47 p.m. She saw Gar at the nursing station terminal before she reached him. He had pulled the results up himself. His credentials gave him system-wide chart access as trauma chief, and he was looking at them with the particular stillness of a man receiving something he had hoped would not be confirmed. She stopped beside him and looked at the screen. Ferritin, 8,400. D-dimer, 4.7. Fibrinogen, critically low. "He's in DIC, Gar said. "Early stage but moving fast," she said. He pulled up the coagulation panel. She was right about all of it, and she wished she wasn't. Closed the terminal window and stood up. "I need to talk to the ICU attending." "Gare, I know," he said. "I know we're outside standard process. But I am not initiating a treatment protocol without involving the attending of record. That's where my line is." He looked at her. "I'll tell him I have new clinical information. I'll tell him I want to consult. I will not tell him what I can't tell him." She nodded. "How fast?" "I'm calling him right now." He already had his phone out. She stood at the nursing station and watched 412 through the glass, while Gar stepped away to make the call. Reyes was still. The monitors showed his pressure was down 3 points from the last reading, which was not dramatic, but was directional. The ICU attending a man named Holroyd, who she knew by reputation as thorough and defensive and units autonomy, arrived on the floor. 11 minutes later. She stayed back from the conversation. This was Gar's moment to navigate, and he was navigating it in a way she respected. Direct, clinical, not mentioning her, not mentioning the source, just presenting the lab findings as information that had come to his attention through interdepartmental awareness and requesting collaborative review. Holroyd was skeptical. She could read it from across the unit, particular body language of an ICU attending being told by a trauma surgeon that his patient had a problem he'd missed. She watched them for 7 minutes. Then Holroyd walked to the room terminal and pulled up the chart himself, and she watched the moment when he saw the labs, and she watched the skepticism shift into something more uncomfortable. He turned around and looked for Gar. Gar said something. Holroyd responded. Then both men walked to the nursing station together, and Gar caught her eye across the unit and gave the smallest possible nod. She crossed the floor to them. Holroyd looked at her with the expression of a man who had been told something he didn't have a category for. "Dr. Gar says you have a proposed protocol." "I have a protocol that addresses the coagulopathy and inflammatory cascade consistent with his current labs," she said. "It's non-standard, but it has a clinical evidence base." "From where?" "From a research context I'm not at liberty to discuss," she said. "I understand that's not a satisfying answer. I'm asking you to evaluate it on its clinical merits." Holroyd looked at Gar. Gar looked back at him. "I've reviewed it," Gar said. "Sophisticated. I want a pharmacist consult before implementation. But the mechanism is sound." Holroyd was quiet for a moment. He was a man being asked to make a significant decision with incomplete information about its origins in front of a nurse he didn't know well, advocating for a protocol she wouldn't fully source. She watched him work through it, and she did not rush him, because rushing this moment would cost more than waiting. "Get the pharmacist," he said finally, "and I want the patient's emergency contact to consent to a protocol deviation." His emergency contact may not be reachable through standard channels, she said. Holroyd's eyes narrowed. What does that mean? She was about to answer when her phone buzzed. She glanced at it. A message from the number she'd stored as nothing. Situation change. Third floor. Now she looked at Gar, then at Holroyd. Excuse me for 2 minutes, she said. Please don't stop the process. She was moving toward the elevator before either of them could respond. The third floor conference room had 5 people in it, now instead of 3. The 2 additions were a woman in her 40s she didn't recognize, and a man in his 30s who had the specific bearing of someone recently off a long flight and operating at the edge of his composure. Voss was standing. He never stood when he could sit, unless something was wrong. There's a complication, he said. She looked at the new people. Who are they? They're from the facility, he said. From Whitmore Station. They arrived 40 minutes ago. He paused. There's been a second exposure event. She felt the temperature of the room change. When? She said. Confirmed 3 hours ago, the woman said. Her voice had the clipped precision of someone delivering a briefing they wished they weren't delivering. The transfer team that brought Reyes here 6 days ago. 2 members of that team have presented with early symptoms. Where are they? Mara said. The woman looked at Voss. Voss looked at Mara. They're in this hospital, he said. 2 people in this building. Symptomatic. She ran the math before Voss finished his next sentence. Incubation period. Exposure timeline. The 6 days since the transfer team had brought Reyes through Calvary's doors, and the specific transmission profile she'd read in the protocol documentation 40 minutes ago. Direct biological fluid contact or sustained close-range respiratory exposure. Low, but not 0. Where exactly, she said. They presented to your emergency department this morning. The woman from Whitmore Station said. Her name, Mara had gathered from context, was Dr. Nessa Farr, a researcher. Not a clinician, which meant she understood the pathogen's biology, but not necessarily the hospital's operational structure. Separate arrivals, approximately 90 minutes apart. We believe they were trying to avoid drawing attention. Did it work? Mara said. They're currently in separate ER bays, Voss said, presenting as respiratory illness. No connection made yet between them or to Reyes. She thought about the ER at this hour, midday moderate volume. The attending on right now would be Dr. Ansel Briggs, who was competent and unhurried, and who would work 2 independent respiratory presentations in the same morning without linking them if they came in 90 minutes apart with different chief complaints. I need to get down there, she said. We need containment first, Farr said. Mara looked at her. Containment in a functioning emergency department without triggering a public health notification is a process that takes hours. His coagulopathy in room 412 has hours, possibly. These 2 new presentations, if they're where Reyes was 6 days ago in disease progression, which the timeline suggests they have more runway. The immediate priority is Reyes. Farr opened her mouth. She's right, Voss said. Farr closed her mouth. The pharmacist consult on the protocol, Mara said to Voss. Is there any way to accelerate the authorization for a read-in physician? We've been working it since you called this morning. The man in his 30s, Farr's colleague, still unnamed, said. The authorization chain requires sign-off from 2 levels we can't compress. Best case is still 4 hours. 4 hours. She did not say what she thought about 4 hours. Then Gar and Holroyd are what I have, she said. And they need enough of the truth to sign off without the full picture. She looked at Voss. How much can I give them? Voss was quiet for a moment, the specific quality of quiet that meant he was calculating risk against operational necessity, a calculation she had watched him make many times in different rooms, in different parts of the world. Tell them it's a research-associated pathogen exposure, he said. Federal facility. Classification level prevents full disclosure. What you can say, the transmission profile is limited. The protocol is evidence-based. and there is federal authority behind the treatment approach that will be confirmed through official channels within the day. Holroyd's going to push back on that. Holroyd pushed back, said the young man near the door, speaking for the first time since she'd arrived. He was looking at his phone. We just got notified. He's escalated to the hospital's chief medical officer. The room shifted. She looked at Voss. Who is the CMO right now? Dr. Philip Straker, Voss said. 61 years old, vascular surgery background, 12 years in hospital administration. She didn't know Straker personally. She knew his name on memos. She knew he was the kind of CMO who appeared at public-facing events and handled policies and left clinical decisions to clinical people unless something threatened the institution. At which point he engaged with the protective reflexes of someone whose primary commitment was the hospital's legal exposure. A classified federal pathogen situation with 3 exposed patients in his building was exactly the kind of thing that would trigger those reflexes. How long before Straker reaches Holroyd? She said. They may already be on the phone, the young man said. She made a decision. I need to be in that conversation, she said. You're a nurse, Farr said, not cruelly factually. With the specific obliviousness of a researcher who understood institutional hierarchies as org charts rather than human dynamics. Mara looked at her. I'm the only person in this building who knows what's actually wrong with the man in room 412, who has the clinical background to manage it, and who has existing working relationships with every physician currently involved. You can send someone with a federal credential through that door, or you can let me go. If you send a federal credential through that door, this hospital goes into formal crisis mode, and containment becomes impossible. She paused. I go up there. I'm 2 nurses having a conversation. Farr looked at Voss. Go, Voss said. She took the stairs again. Faster this time. The 4th floor was audibly different when she came through the stairwell door, a different register of activity. Voices with the particular clipped urgency of people managing a situation that had changed while they were in the middle of something else. She could see from the stairwell doorway that Gar and Holroyd were no longer at the nursing station. They were in the ICU attending's office, a glass-walled room at the end of the unit, and there was a 3rd person on the phone who she didn't recognize from this angle. She crossed the floor. She did not knock. She opened the door and stepped in, which she recognized as a social transgression that would cost her something and which she was prepared to pay. The 3rd person on the phone was, she understood immediately. Straker, she'd identified him from the photograph on the hospital's administrative page, which she'd pulled on her way up. He was taller in person, with the silver-haired solidity of a man who had once been a surgeon, and still carried himself like one. He looked at her when she came in with the expression of a person interrupted by someone who has no obvious reason to be in the room. Holroyd looked at her with something closer to relief, which surprised her. Gar looked at her with the expression he'd been giving her lately, the one that meant, I have been waiting for you to tell me what's actually happening. Straker lowered the phone. Who is this? This is Nurse Doyle, Gar said. She's the one who flagged the patient's current status. Why is a nurse in this conversation? Because she knows more about what's wrong with your patient than anyone else in the building, Gar said, with a flatness that she recognized as the particular register he used when he had committed to a position and was no longer interested in negotiating about it. She looked at Straker directly. I need 2 minutes, she said, and then you can decide whether to keep me in the room or not. He looked at her for 3 seconds. 2 minutes, he said. She used them carefully. Federal facility. Research-associated exposure. She used that phrase exactly as Voss had given it. Classification constraints. Transmission profile limited to direct contact. 3 individuals currently at Calvary, 1 in ICU, 2 in ER. Protocol in hand, evidence-based, federal authorization, incoming within the day. The clinical window for the ICU patient was narrowing. When she finished, Straker looked at the phone in his hand. then at Holroyd, then at Gar. Federal Research Facility has placed contaminated individuals in my hospital, he said, without notifying administration, and is now asking me to implement an undocumented treatment protocol on the advice of a nurse. On the advice of someone with specific expertise in this pathogen's behavior, she said. The nursing credential is the credential she has here. It doesn't reflect the full scope of what she knows. Gar had said she, talking about her in the third person, while she was in the room, which was technically odd, but which she understood as him. Lending her his institutional weight in the only way available to him in this moment, which was to put his name next to her assessment in front of the CMO. Straker stood up. He walked to the glass wall and looked out at the ICU floor, the monitors, the beds, the controlled machinery of critical care. She watched him think. He was not a stupid man. He was a man whose job had trained him to think in terms of liability and protocol and defensibility, which was not the same as being stupid, but which sometimes produced the same result as cowardice when speed was required. I need to call legal, he said. Mr. Straker, she said, with respect. His fibrinogen is critically low and falling. His D-dimer is 4.7. He is developing DIC in real time, and the current protocol is not addressing it. She paused. The time you spend on the phone with legal is time his coagulation cascade is running. Straker turned around. If you're wrong, he said. Then I'm wrong, and we have a documentation problem, she said. If we do nothing and I'm right, we have a death. The room was quiet. Do it, Straker said. He looked at Holroyd. Get pharmacy on the line. I want a record of every decision point from this moment forward. He looked at Gar. You're co-signing the protocol? Yes, Gar said. Straker looked at her last. The look was long and unreadable, and she held it without flinching. Someone is going to explain everything to me, he said. Before this day is over. Yes, she said. They will. Pharmacist consult took 22 minutes. His name was Dr. Orrin Mac Young, meticulous, with the particular combination of skepticism and flexibility that good clinical pharmacists developed when they'd been practicing long enough to know that unusual situations sometimes required unusual approaches. He went through the protocol page by page, asked 12 specific questions, flagged 2 interaction concerns that she already knew about and walked him through, and then said, with the studied neutrality of someone covering themselves in writing, I can support this with appropriate monitoring parameters documented. Gar signed, Holroyd signed, Mac countersigned. The first medication administering began at 2:34 p.m. She stayed in the room while Park, who had been told only that the treatment plan had been revised based on new specialist input, hung the first infusion. She watched the drip rate, watched the monitor, watched Reyes's face with the particular vigilance of someone who had administered protocols like this in conditions where the monitoring equipment was a pulse, oximeter clipped to a finger, and the backup plan was her hands. The first 30 minutes were the window. If he was going to have an adverse reaction, and the protocol's primary risk was a paradoxical inflammatory response in the first administration cycle, it would show in the first 30 minutes. She did not leave the room. She stood at the corner of the bed where she could see both the patient and the monitor without turning her head. At minute 19, his pressure dipped. Not dramatically, 4 points systolic, but enough. Hold the rate, she said to Park. Park looked at the monitor and looked at her. Just for 2 minutes, Mara said. Let's see if it stabilizes. It did. At minute 23, the pressure recovered. She nodded to Park. Resume. At minute 31, his oxygen saturation climbed 0.5 point. Small, almost insignificant, but directional. She exhaled through her nose and felt the specific fatigue of sustained high-stakes attention releasing very slightly from her shoulders. Gar was in the doorway. She hadn't heard him come back. Holdison, she said. I can see that. He came into the room, stood on the opposite side of the bed from her, and looked at the monitor and at Reyes and at the infusion running through the IV line. The two in the ear. I need to go down there. I'll come with you. She looked at him. You don't have to. I know, he said. They left Park with clear monitoring parameters and a direct line to page them at any deviation, and took the elevator to the first floor. The emergency department at 3:10 in the afternoon was running at capacity, a normal Tuesday volume, with the usual mixture of urgent and non-urgent cases, creating the usual kind of controlled disorder. Briggs, the attending, was managing from the center of the room with the relaxed authority of someone who had been doing this for 20 years and who had stopped finding it dramatic. She found the two transfer team members in bays 9 and 11, opposite ends of the department, which confirmed they'd made a deliberate effort to avoid being associated with each other. Bay 9 held a man in his late 30s named, per the registration, David Ostroff, presenting with fever, productive cough, and myalgia of 3 days' duration. Bay 11 held a woman in her early 40s, registered as Clara Hind, presenting with simpler symptoms, plus the beginning of a rash across her upper chest that the triage nurse had photographed and flagged as uncertain etiology. The rash was what told Mara the timeline. The rash was not in the protocol she'd read. It wasn't part of Reyes's documented progression. But it was consistent with what she knew about the pathogen's behavior in the first week of infection, a cutaneous manifestation that appeared in roughly 30% of cases, and that the research literature described as benign but clinically significant as a staging marker, which meant Hind was approximately 5 to 7 days post-exposure, and Ostroff, who didn't have the rash, was either earlier or in the 70% who didn't present it. She reviewed both charts at the nursing station, without entering either bay, because she needed the picture before she walked in and changed what was happening. Briggs saw her at the terminal. "You're off shift," he said without accusation. "Checking up on something?" "New consult from upstairs," she said, which was technically accurate. "Can I review bays 9 and 11 with you?" Briggs was the kind of physician who didn't ask unnecessary questions when someone he trusted flagged something. Pulled up both charts. He looked at them side by side and then looked at her. "Two respiratory presentations 4 hours apart," he said. "I was going to route them to separate admission teams." "You're seeing something." "I think they may be linked," she said. "Same exposure source. And I think their presentation is going to be similar to a patient currently in the ICU." Briggs was quiet for a moment. The guy in 412. She looked at him. "How do you know about 412? "Word travels," he said. Lab was talking about the abnormal panel, and Gar going to the ICU in the middle of the day with a nurse trailing him is not exactly invisible. He looked at her steadily. "What's going on, Mara?" She made a decision, not the same decision as the ones she'd been making all day, which were about clinical management and information control. This was a different kind. The decision to trust someone based not on authorization or protocol, but on the simple assessment that he was competent. He was already partially aware, and she needed him. "It's a research-associated exposure," she said, keeping her voice low and even. "Federal facility. The transmission risk is low with contact precautions. I can't give you than that right now. I can't give you more than right now. But I can tell you the treatment protocol that worked in 412 is likely appropriate here, and these two need to be moved to negative pressure rooms before anyone else manages their care." Briggs looked at her for a long time. The ER noise continued around them, the mechanical, human noise of a department in motion, entirely unaware. "Negative pressure rooms," he said. "We have 2 available." "Corridor." "Yes." He stood up. "I'm going to go have a very boring conversation with both patients about room placement for infection control purposes," he said. "And then I'm going to need you to stand next to me when I make a call that I do not have enough information to justify to anyone." "I'll be there," she said. He walked toward Bay 9 with the unhurried, deliberate gait of a physician who had decided what he was going to do and was not performing urgency, because performed urgency see was how panic spread. Gar appeared beside her at the nursing station. He had been standing 15 feet back, close enough to hear, far enough to be deniable. "How bad is the ER exposure risk?" he said quietly. "Low," she said. The triage nurse who did the initial assessments was wearing standard precautions. The Bay staff similarly. "The pathogen requires sustained close contact." She paused. "We should still do a precautionary exposure review." "I'll coordinate with Straker. He's not going to like it." "He's going to like it significantly less if we don't do it," Gar said. She almost said something, then something about the last 2 weeks. The incident report, the night shift, the way the morning in the administrative conference room had felt like a negotiation about her right to be in rooms she'd been qualified to be in all along. ER was not the place, and the moment was not the time, and she had never been particularly good at saying the things that were better said when they could be said properly. She started moving toward Bay 11, where Clara Hind was waiting with her rash and her careful story. By 5:40 p.m., both transfer team members had been moved to negative pressure isolation rooms in the East Corridor, consented to the treatment protocol, the cover, under the cover language of specialist recommend intervention, and had their first medication administrations confirmed by Gar, who had now signed 3 protocol orders in 5 hours and who had stopped commenting on this fact. Mac, the pharmacist, had modified the dosing for the ER patients based on their presentation stage, which she'd recommended and which he'd independently verified was appropriate. The monitoring parameters were in place. The assignments for a 2 most isolation corridor were the 2 experienced RNs on the afternoon shift, both of whom had been given enough information to manage safely and not enough to panic publicly. Straker had been on 3 calls with federal contacts she assumed were routed through Voss's team. Each call had produced a version of him that was slightly less hostile and slightly more cooperative than the previous one, which she interpreted as Voss, delivering the promised authorizations through whatever back channels he used when situations required back channels. She was at the nursing station in the ER at 5:47 when the overhead PA announced a request for Dr. Gar to report to the main conference room on the administrative floor. And then, 30 seconds later, a second announcement requesting Dr. Holroyd. And then, in a development she had not expected, a third, a request for Nurse Mara Doyle to report to the administrative conference room. She looked at the PA speaker as though it had said something in a language she almost recognized. Briggs, passing behind her, said, "That's the big room. They only use that room when something is actually on fire." She took the elevator. The conference room on the administrative floor was different from the 3rd floor room where she'd met Voss that morning. Larger, formal, with a long oval table, and the kind of institutional seriousness that came from wood paneling and too many framed credentials on the wall. There were 8 people in it when she arrived. Voss was there. Farr was there. The unnamed intelligence man and the young man from the door. Draker, Holroyd, Gar, and a woman she didn't recognize, early 50s, civilian clothes with the specific crease patterns of a long flight, a federal identification badge visible on a lanyard she hadn't bothered to conceal. The badge said Hartwell E., and below the name, a designation she recognized from a different context entirely. She sat down in the chair Gar had positioned slightly away from the table, as though saving it, which she noted and didn't comment on. Hartwell looked at her for a moment, the assessing, neutral look of someone who made decisions about people for a living and had long since stopped being apologetic about it. "Chief Doyle," she said. "I'm not," she started. "I know," Hartwell said. Old habit. She opened the folder in front of her. "Callum Reyes is stable. His coagulation markers are improving. The immunomodulation sequence is progressing within protocol parameters." She looked up. "Your intervention saved his life." Mara said nothing. "2 secondary cases are early enough in progression that full recovery is expected with protocol treatment." Hartwell paused. You identified all 3 cases, coordinated the clinical response, managed 3 separate physician relationships to get authorization, and maintained operational security in a civilian environment for approximately 8 hours. She paused again. While working under an active incident report that a senior physician filed because you correctly identified a tension pneumothorax before he did. Gar looked at the table. Holroyd looked at Gar. Straker had an expression she could not fully read somewhere between vindication and the particular discomfort of a man who had almost made several very bad decisions and was aware of it. The incident report, Hartwell said, looking at Straker, will need to be addressed. It's already being addressed, Straker said. He did not look at Gar when he said it. Gar did not look at Straker. We began that process this morning. Hartwell nodded. She looked back at Mara. There's something else. Psychofacially, the room had settled into a quality of attention that Mara recognized the particular silences of people who knew something was coming and were waiting to see how it landed. Containment failure at Whitmore Station, Hartwell said. It wasn't an accident. She kept her face still. We know that, Hartwell continued, because the transfer protocol that moved Reyes to this facility was internally compromised. Someone within the facility's operational structure manipulated the containment sequence to ensure the exposure occurred, and then arranged for the transfer team to be deployed before their exposure status was confirmed. She paused. Which means there is a person, possibly more than one, who deliberately exposed 3 people to a modified pathogen and then placed all 3 of them in a civilian hospital in Dunmore, Pennsylvania. The silence in the room lasted 3 full seconds. Why here, Gar said. Hartwell looked at him. Then at Mara. Mara felt something go cold at the base of her spine. Because Kessel was here, she said. Her voice was even. They knew Kessel was the read-in physician at this facility. They knew if Reyes arrived here in crisis, Kessel would manage him using the protocol, which would have left a documented record of classified treatment methods in a civilian hospital system. She paused. They wanted the protocol exposed. They wanted it in discoverable records. Hartwell held her gaze. Correct. But Kessel had a cardiac event, Mara said. 4 days before Reyes arrived. Yes, Hartwell said. Which is why Reyes has been receiving incorrect treatment for 6 days instead of dying within 48 hours with a classified protocol in his chart. She paused. Someone's plan ran into a man's heart attack, and then it ran into you. The room was very quiet. Hartwell's expression shifted not dramatically, just the slight movement of someone arriving at the thing they actually came to say. We've identified the person who compromised the containment protocol, she said. We have communications, access logs, financial records. She opened a second folder and placed a photograph face-up on the table. Mara looked at it. She recognized the face immediately. Not from her operational past, not from Whitmore Station or any classified context. From the hallways of Calvary Regional Medical Center, where she had passed him unremarkably for 3 years, where he had seemed entirely peripheral, where he had been so consistently in the background that she had constructed no mental file on him worth keeping. Dr. Raymond Kessel, who was not in the cardiac ICU at Mercy General in Scranton. His cardiac event, Voss said from across the table, with the flat inflection of someone delivering information they wish they weren't delivering, was staged. The photograph sat in the center of the table, and nobody spoke for a moment that felt longer than it was. Mara looked at Kessel's face, the unremarkable face of a man she had passed in hallways for 3 years, without ever constructing a reason to look at twice, and she felt something shift in her understanding of the last 6 days. Not dramatically, more like a key turning in a lock she hadn't known existed, the mechanism releasing with a click she could feel, but not quite hear. How long? She said. Hartwell looked at her. How long has he been working against us? How long has he been in this hospital? 7 years at Calvary, Voss said. Read into the Whitmore operation, 18 months ago. We assessed him as reliable. You assessed him as reliable, she said. And then he staged a cardiac event and went somewhere you haven't found him. We know where he is, Hartwell said. He's in a private residence in upstate New York, approximately 40 miles from the Whitmore facility. He drove there from Scranton 4 days ago, using a vehicle registered to a shell entity we've been tracking since yesterday afternoon. She paused. He's been there since. He appears to be waiting. Waiting for what? Gar said. Hartwell looked at Mara. Not at Gar, at her. Waiting to see if Ray has died, Mara said. Protocol appeared in the records. If the plan worked. Yes, Hartwell said. Mara looked at the photograph for another moment. Then she turned it face down on the table, which was not a dramatic gesture, just a practical one, a way of moving past what was known and toward what needed to be done. You have enough to take him, she said. We have enough to act, Hartwell said. We're coordinating with federal law enforcement as of this afternoon. There will be an apprehension at the residence tonight. She paused. He will not be running. The table was quiet. Straker was looking at the wall with the expression of a man who had spent 20 years managing a hospital and had never once anticipated a conversation like this one. Holroyd had his hands folded on the table with the deliberate stilts of someone choosing to hold himself together in front of people he didn't know. Gar was looking at Mara with the expression she was starting to read, the one that meant he was revising something, not just tactically, but in some more fundamental way. There's the administrative matter, Hartwell said, turning to Straker. The incident report. The personnel actions taken against Nurse Doyle over the past 2 weeks. Straker straightened slightly. We are already in the process of... I'm not asking about the process, Hartwell said. Her voice was even, but it had an edge to it that cut through Straker's institutional language like a blade through paper. I'm telling you that the record needs to be corrected completely and formally, and that the circumstances of the personnel actions need to be reviewed by your board, and that the federal office I represent will be following up to confirm that review happened. She looked at him steadily. Is that clear? Yes, Straker said. He did not qualify it, which she suspected Hartwell had expected him to. Hartwell looked at Gar last. Dr. Gar, the incident report was filed by you. Gar looked at her directly. Yes, and the personnel action that followed. I requested it, he said, through administrative channels. I didn't directly order it, but the request came from me. He said it without evasion, which she had come to understand was his particular quality. He did not hide from his own decisions, even when they were wrong. That will need to be part of the formal review, Hartwell said. I understand, Gar said. He didn't look at Mara. She didn't look at him. The moment had a kind of compressed weight that she thought they would deal with differently, separately, later. Hartwell closed her folder. I think that covers what needed to be addressed in this room. She looked at Mara. May I have a few minutes? Separately. The hallway outside the conference room was empty. The administrative floor at this hour had its own particular silence, the offices still occupied, but everyone quieter, the bureaucratic machinery of the day winding toward its close. They stood near the window at the end of the corridor, the October light coming in pale and sideways, the parking lot below ordinary and amber in the early evening. Hartwell was shorter than she'd seemed at the table 5'4", maybe, with the kind of posture that added height. She looked at Mara without the formal distance of the conference room. You did well today, she said. I'm not saying that as an official assessment. I'm saying it as the plain truth. 3 people are alive who might not be, Mara said. The relevant fact. It is, Hartwell agreed. It's also true that you've spent 3 years hiding from work you're built for, and that today happened because the circumstances gave you no choice, and that you still managed it better than most people I would have sent in deliberately. Mara looked out the window. A man was walking through the parking lot with a child on his the child reaching up for something invisible. Ordinary. The whole ordinary world going on outside this building that had spent the last 8 hours containing something it didn't know how to name. I left for a reason, she said. I know what the reason was, Hartwell said. I read your file completely, not just the service record. She kept looking out the window. The decision you made at the end of your last deployment, Hartwell said. The one that ended your career. You were right. Mara turned to look at her. The after-action review found errors in the command decision, not in your medical call, Hartwell said. Finding was classified at a level that didn't reach you because you were already out. I'm telling you now, 'cause you should have been told then. The hallway was very quiet. She had spent 3 years with that decision, lodged somewhere it was not comfortable to carry. Not guilt exactly, because she had been clinically correct, and she had always known she had been clinically correct, but a specific kind of weight that comes from being right in a way that nobody with authority confirms. The weight of a judgment made alone in the dark, with consequences that outlasted the moment. Hartwell's words didn't dissolve it. 3 years of weight didn't dissolve in a hallway. But something in the architecture of it changed the shape of it, the way it sat. All right, Mara said. Hartwell looked at her. I'm not here to recruit you back into operational work. That's not what this is. But I am here to tell you that what you've been doing here for 3 years is not hiding, even if it felt like it. You've been building something. And today, what you built here, the relationships, the knowledge of this hospital, the 3 years of showing up and being reliable, that's what made the difference. Mara thought about that, about the 16 minutes early every morning. Supply discrepancies she fixed without being asked. The overnight catch-up charting, the medication reconciliation, the 11 days of night shifts she'd absorbed without complaint. The small, invisible, unglamorous accumulation of being someone who showed up and kept showing up regardless of what it cost her. It didn't feel like building anything, she said. I know, Hartwell said. It rarely does. She handed Mara a card. Plain, no federal seal, just a phone number and the initial E. If you ever want to talk, she said. Not operationally. Just talk. She walked back toward the conference room. Mara stood at the window a moment longer, then turned and took the stairs. Callum Reyes's numbers at 8 p.m. were the best they'd been since his admission. She stood at the glass of room 412 and read them. The way she'd been reading numbers all day, clinically, precisely, letting the data mean what it meant without embellishing it. His ferritin was trending down. His D-dimer had plateaued, which wasn't improvement, but was the cessation of deterioration, which was the necessary precondition for improvement. His oxygen requirement had decreased 2 points. He was still sedated, still ventilated, still a long way from the road back to a life in Phoenix, with a daughter who presumably didn't know what her father had been exposed to or how close it had run. But he was moving in the right direction. Park was at the end of her shift. She found Mara in the hallway and said, His evening labs just came back. Do you want to see them? Yes, Mara said. They went to the terminal together. Park pulled up the results, and they stood side by side and read them. 2 women at the end of a very long day, looking at numbers that were incrementally and imperfectly, and without any guarantee, improving. Whatever you flagged this morning, Park said. Whatever changed the protocol. It's working. It's working so far, Mara said. You're not going to take that. Take what? The moment. Park looked at her. You're not going to just let yourself have the moment where the thing you did is working. Mara looked at the numbers on the screen. I'll have the moment when he's extubated, she said, and not before. Park made a sound that was not quite a laugh and not quite a sigh. Fair enough. She signed out, and the next shift nurse took over, and Mara stood in the hallway of the ICU at 8:19 p.m. 16s. After she'd clocked in for a day shift she hadn't even been scheduled for, and felt the fatigue arrive properly, for the first time not the managed. Functional fatigue she'd been running on all day, but the full weight of it, settling into her legs and her shoulders and behind her eyes. She was on her way to the elevator when Gar came out of the physician workroom. He saw her. She saw him. Neither of them pretended not to. They stood in the hallway for a moment with the ICU behind them and the elevator ahead. "I have to say something," he said. "You don't have to," she said. "I know I don't have to," he said. "I'm going to anyway." He looked at her with the direct, uncomfortable openness of a man who had decided to stop managing a situation and start being honest about it. "What I filed was wrong. Not procedurally wrong, it was procedurally correct, which is part of what made it wrong. I used the institutional tools available to me to manage someone who made me uncomfortable." She waited. "You made me uncomfortable because you were right," he said. "And because you were right in ways I didn't have a framework for. And because I didn't ask what your framework was. I just decided it was insufficient." He paused. "That was a failure of judgment. Not clinical judgment. Personal judgment." She looked at him. "I know," she said. "I know you know," he said. "I'm saying it anyway because it needed to be said directly and out loud and not in an administrative memo." She understood that. She understood the difference between institutional acknowledgement and the kind that required someone to stand in a hallway and simply say the true thing without the protection of paperwork around it. "The privileging pathway," she said. "You mentioned it in the meeting with Hollis." "It's real," he said. "It exists. It would take 3 to 4 months to process through the credential committee, and I would submit the supporting recommendation personally." He paused. "If you want it." She looked at him. "What would it change?" "Formally, your authorized scope at this hospital. Practically," he paused, "you'd be able to do what you did today without having it be a question." She thought about that for a moment. "I'll think about it." "That's all I'm asking," he said. He went back into the workroom. She took the elevator down. Raymond Kessel was apprehended at 11:47 p. That night at a rented residence in Roanoke Falls, New York, by a federal team that Voss's office had coordinated with 2 other agencies whose names did not appear in any press release the following morning. He did not resist. He was cooperative in the way that people sometimes come when the distance between where they are and where they thought they'd be becomes impossible to maintain. She learned about it from Voss, who sent a text at 12:03 a.m. that said only, "Done." She was in her apartment when it came. She was sitting at the kitchen table with a cup of tea she'd made, and not yet drunk, looking at the wall above the stove, where she'd taped a photograph of her sister's kids from last Christmas. Normal, ordinary. Photograph of a person who wanted a normal life. She looked at it for a while. Then she picked up the tea. Formal board review convened 14 days later. It was not public hospital board proceedings, rarely are, but its outcomes were. The incident report filed by Dr. Gare was formally withdrawn from her personnel file, replaced by a documented statement from the chief medical officer, acknowledging that the circumstances of the filing had not reflected an accurate assessment of her clinical conduct. Every document from the night shift reassignment was similarly reviewed, annotated, and corrected in the permanent record. Straker presented the findings to the board himself. She was told this by Hollis, who called her the morning after the meeting with the particular tone of someone delivering news that was better than expected. "He was thorough," Hollis said. "More thorough than I expected, honestly. He included the mass casualty event, the ICU case, the ER presentations. All of it, without minimizing any of the procedural irregularities." "Did he mention his own role in the night shift reassignment?" Mara said. A pause. He acknowledged that the administrative action was taken without sufficient review of the underlying clinical record, Hollis said carefully, which is as close as Philip Straker gets to saying he made a mistake. It wasn't everything. She knew that. The administrative language of institutional correction was not the same as justice in any clean or satisfying sense. It was the slow, imprecise grinding of a system attempting to correct itself, which it did badly and late and with significant friction. But it happened. The record changed. That was real. Gare submitted the privileging recommendation 8 days after their hallway conversation. She knew because she received the formal notification from the credential committee, which was how those things worked, the machine moving on its own schedule, indifferent to the human texture of what had preceded it. She responded to the notification, confirming she wanted to proceed. The review process was 3.5 months long, which was standard. She worked through it the same way. She worked through everything showing up, doing the job, staying present to the work rather than the outcome. Committee asked for documentation she provided. They asked for references she gave. Gar's letter, which she read once through the process, and which she thought she would not read again for a long time because it was more honest than she'd expected. And honesty, when it arrives late, specific weight that takes time to carry correctly. He wrote about the Cobb case, about the mass casualty event, about the ICU, about the quality of clinical reasoning he had observed over 3 years and had not, until recently, chosen to see clearly. He did not explain why. The letter did not ask forgiveness. It simply stated facts. She thought that was probably the right call. Callum Reyes was extubated on day 9. She was not in the room when it happened. She was working a day shift in the ER, and she found out from Park, who sent a message at 2:14 p.m. that said, 412 is breathing on his own. Thought you'd want to know. She was at the medication cart when she read it. She set the phone down and stood very still for approximately 4 seconds, the amount of time it took to let a fact arrive completely, and then she picked the phone back up and typed, "Thank you." On day 14, she was coming off shift when she passed the family waiting area near the elevator bank and saw a man in a wheelchair being pushed by a woman about his age, his wife. She guessed toward the exit. He was thin, the kind of thin that illness produces that takes months to reverse. He was wearing clothes that were slightly too large for him now, which was the most honest visible evidence of what he'd been through. He looked up when she passed. She didn't know if he knew who she was. She didn't know what Voss or Hartwell had told him about the people who had managed his care, or what version of the story he'd been given, or whether the classified dimensions of it had been disclosed to him or kept at the level of federal abstraction. He looked at her for a moment. "Thank you," he said. Simple, direct, no elaboration, no drama, no more information than those 2 words. She didn't know what he was thanking her for. She suspected he knew more than he was saying, which was a quality she recognized. "Take care of yourself," she said. His wife pushed him toward the exit. The automatic doors opened on the November air, cold now, properly cold. The Pennsylvania autumn, having finished its business and handed off to something grayer and more serious. She watched them go and then took the elevator up to the locker room and changed out of her scrubs and sat on the bench for a moment, pulling on her jacket. She was not entirely fine. That was important to know about herself. The 3 years of a careful distance she'd maintained from her own past, had been compressed by the last several weeks into something she was still sorting through the conversation with Hartwell. The thing about the after-action review, the fact that she'd been right, and someone finally said so. That didn't close cleanly. People who told you that clarity was a destination rather than an ongoing condition were people who hadn't lived in the middle of something genuinely complicated. But she was better than she'd been. That was also real. Credential Committee issued its determination on a Thursday morning in late January, and the notification arrived in her hospital email at 9:47 a.m. while she was charting in the ER. She opened it between 2 patients. The language was institutional and dry, which was appropriate, and it conveyed with institutional precision that her application for extended clinical privileging had been reviewed and approved, and that effective immediately, she was authorized to perform a range of clinical interventions within the hospital system that had previously been outside her formal scope, and that her new credential designation would appear in the staff directory as trauma nurse clinician, a designation that had existed in the hospital's credential structure for 12 years and had never once assigned to anyone. closed the email. She finished charting. She went to her next patient, a 40-year-old man with a laceration on his forearm from a workshop accident. Calm about it in the way that calm people are about things that hurt but aren't catastrophic, and she assessed the wound and organized the repair and talked to him the way she talked to all her patients, present, clear, human. His name was Gary. He had paint on his shoes and a wedding ring worn smooth from 20 years of wear. And he was worried about whether he'd be able to drive home, which she reassured him he would. Irrigated the wound and closed it in 3 neat layers, and told him to come back in 10 days for suture removal, and he thanked her, and she moved on. Gar found her at the nursing station at noon. He didn't make a production of it. He just appeared beside her at the terminal and said, "I saw the committee notification." "Yes," she said. "Congratulations." "Thank you." He stood there for a moment with the look of a man who had several more things he could say and was deciding which ones were worth saying. She gave him the space. "The Cobb case," he said. "The chest tube placement. You were right about the positioning from the start." She looked at him. "I moved the kit to be right," he said. "Not because it was better. Because I walked in and saw a nurse had set up the bay, and I assumed without looking that I could improve it." He paused. "That's a specific kind of wrong that I hadn't examined clearly until recently." She thought about what to say to that. She thought about the months of invisible work, the 16 minutes early, the catches nobody acknowledged, the incident report sitting in a personnel file, while the patient she'd correctly read went home with working lungs. "I know you know that," she said. "I'm not going to tell you it didn't matter." "I know," he said, "but I'm also not going to spend energy on it anymore," she said. "There are patients to manage." He looked at her. Something moved across his expression that wasn't quite a smile, but was in the same family. "There are," he said. He walked away. She turned back to the terminal and pulled up the next chart. The following week, a reporter from the regional newspaper called the hospital's communications office, looking for comment on rumors about a federal investigation linked to a Calvary regional physician. The communications office referred the inquiry to Straker, who gave a statement confirming that a former staff member, Eunice Butu, had been the subject of a federal proceeding and that the hospital had cooperated fully with the relevant authorities. Raymond Kessel's name appeared in the public record 2 days later in a federal court filing that listed charges she did not need to read in detail to understand the shape of. Filing was picked up by a wire service and ran in 4 regional newspapers and 1 national outlet, all of which focused on the federal research angle, and none of which knew anything about the specific patients in a Dunmore hospital who had almost died because a man had decided that information was worth more than the people carrying it. She read the headline on her phone during a break and then put her phone in her pocket and went back to work. Kessel pled through federal channels 6 weeks later. She was not called as a witness. She was not needed in any courtroom because the evidence against him had nothing to do with her and everything to do with communications, intercepts and access logs and financial transfers that told their own complete story without her involvement. She was grateful for this, not because she would have been unwilling. She would have said whatever was true in whatever room required it, but because there was a specific freedom in being unnecessary to the legal mechanics of someone else's accountability. The world had processes for dealing with Raymond Kessel, and those processes were doing their work, and she didn't need to be in the room for it. What she needed to be in was this hospital, this department, this city. Not because it was easy, or because the people in it had always treated her well, they hadn't. And that was a fact she didn't need to reconstruct as something more graceful than it was. But because this was the work she had chosen, and she had chosen it with clear eyes, and the 3 years she'd spent doing it in the dark, unremarked and underestimated and quietly indispensable, had built something real. She had not needed anyone to watch in order to be good at this. That was what nobody had understood about her, not Gar, not Straker, not the resident, who had laughed in the trauma bay on a morning that now felt like a different lifetime. They had looked at someone who did excellent work, without demanding recognition for it, and concluded that the work was probably not that excellent. The logic of visible reward. If no one is applauding, there must be nothing worth applauding. Patients, whose IVs she'd started correctly. The bleeds she'd caught on the visual, read before the attending's x-ray came back. Teenager in Bay 7, whose arm had felt far away and who, last she'd heard, was in outpatient rehabilitation in Scranton and making progress. The man in Bay 1, on the worst night Calvary had seen in a decade, whose pressure had recovered after a needle she'd placed in the dark while people were looking elsewhere. They were alive. They didn't know her name. She didn't need them to. The work was real, whether or not anyone was watching. That had always been true. The last several months had simply made it visible to the people who shared the building with her, which changed their understanding, but not the underlying fact. On the first warm day in March, a false spring, the kind that arrives in Pennsylvania before winter is done, and makes everyone briefly optimistic, she arrived at Calvary Regional at 6:42 a.m., 16 minutes before her shift, and did her walkthrough. The overnight staff had left 2 supply discrepancies and a documentation gap in Bay 3. She fixed the discrepancies, flagged the documentation, and positioned herself at the nursing station. Patel, who had rotated back through the ER for his emergency medicine block, arrived for the morning shift and found her already there. He'd grown into his residency since the mass casualty event. Something in the way he moved had settled, the anxious energy replaced by something more grounded. "Good morning," he said. "Morning," she said. He looked at the board. "Quiet night?" "Mostly," she said. "Bay 6 is a 63-year-old with abdominal pain we haven't sourced yet. I'd want to recheck her labs when the 7 o'clock draw comes back." He nodded, pulling up the chart. On it, they worked through the handoff at the same pace they always did, steady, structured, without performance. Outside the windows, the March light was coming in at a low angle that turned the parking lot briefly gold before the day rose. And the light went ordinary. Her phone buzzed. She glanced at it. A message from her sister in Spokane. "Kids made you something at school." "Can I send it?" She typed back. "Please." A photo arrived 30 seconds later, a piece of construction paper covered in the energetic, slightly chaotic artwork of children who hadn't yet learned that art was supposed to look like something specific. Her niece had written, in the large, confident letters of a 7-year-old who believed absolutely in the importance of communication, for Aunt Mara, who helps people. She looked at it for a moment. There was nothing clean or resolved about who she was. She knew that the history she carried was complicated, and the choices in it were not all good ones, and the 3 years she'd spent constructing a quiet life had been real years, real choices, and not something that a few weeks of crisis could simplify into a clean before and after. She was still working out what the after-action review meant, and what Hartwell's card meant, and what it meant that the man in the wheelchair had looked at her in a hospital corridor and said 2 words that carried more weight than a commendation would have. But the 7-year-old on the piece of construction paper had it right. She helped people. That was the thing that was true on the worst days and the quietest ones, in the mass casualty hours, and the ordinary Tuesday afternoons, in the rooms where the monitoring showed good numbers, and the ones where she stood and did the math and knew the news was going to be hard. She had spent 3 years worried that the life she'd built here was a retreat from the person she'd been. She understood now, not cleanly, not without remainder, but genuinely, that it was not. It was the same work, in a different room, with different tools. The core of it had never changed. She saved the photo and put her phone away and went to Bay 6 to check on the 63-year-old with the abdominal pain. The woman was awake. Her name was Rosalind. She was a retired school teacher who had driven herself to the ER at midnight because something didn't feel right, which was its own kind of bravery, the ordinary, undramatic bravery of a person who trusts the signal her body is sending and acts on it without waiting for permission. How are you feeling? Mara said. Rosalind looked at her with a candid appraisal of a woman who had taught other people's children for 30 years and was good at reading sincerity. Better than last night, she said. Not good, but better. That's the direction we want, Mara said. She checked the IV, reviewed the vitals on the room monitor, asked the questions that mattered, and listened to the answers without rushing them. Outside the bay, the department was picking up its morning pace, voices, wheels, the particular energetic hum of a place that was always either managing something or preparing to. The world continuing its ordinary, difficult business. She stayed until she had what she needed. Then she updated the chart, flagged Patel, and moved to the next bay. This was what it looked like. Not the dramatic reversal, not the moment of public vindication, not the photograph in the newspaper or the commendation letter or the acknowledgement from the person who had spent months dismissing her. Those things had happened, and they were real, and she would not pretend they didn't matter, because they did. But the work was this: the next patient, the next chart, the next set of numbers to read and respond to, the next person alone in a room with something wrong and needing someone who could see clearly and act without flinching and stay present when staying was difficult. She was that person. She had always been that person. The difference was simply that the building she worked in had finally learned to see it.